This video continues Chapter 13 of OEC 6 by looking at respiratory emergencies. We're going to consider the common respiratory emergencies that you may encounter as an OEC technician, and specifically we'll identify the most common cause of airway obstruction and look specifically at asthma, COPD, hyperventilation, pulmonary embolisms, and pneumothoraxes. We'll look a little bit as well at the assessment of a patient with difficulty breathing. So some key terms that we encounter through this video will be highlighted in red. One of the most urgent emergencies that we may encounter is choking or airway obstruction. The tongue is the most common cause of airway obstruction, and so we see this as part of our primary assessment, ensuring airway patency, and our methods for reducing the obstruction in the airway can be head tilt, chin lift, or jaw thrust. Now, additionally, we may be concerned about a foreign body obstruction, and so we also, in Chapter 9 on airway management, look at finger sweep, suction. We consider gravity and positioning, and as part of our CPR training, consider abdominal thrusts too. Another respiratory emergency is asthma, which is due to sudden constriction of the bronchioles in the lower airway. An acute asthma attack can be reversed by treatment, and so we'll look later at the skill of assisting a patient with their inhaler. However, understand this can still be life-threatening. The exact cause of asthma is not known. However, it could be related to either genetics or environmental triggers, and we see the idea of a bronchospasm, the contraction of the bronchioles, as a result. Strenuous physical activity or exercise-induced asthma can also occur. If a severe asthmatic attack does not respond to the patient's inhaler, the immediate dispatch of advanced life support is critical. Chronic obstructive pulmonary diseases are exactly as described. Chronic meaning long-term, obstructive is self-evident, and pulmonary disease, we have this long-term inflammatory lung disease. A couple of types of these will be chronic bronchitis or emphysema. Symptoms include breathing difficulty, a cough, and excessive mucus production. Most often the cause is long-term cigarette smoking, but also possibly prolonged exposure to dust or chemicals in an industrial environment or pollution and environmental irritants. People with COPD are at an increased risk of developing heart disease. It cannot be cured, but we can improve the patient's oxygenation. So to distinguish between chronic bronchitis or chronic emphysema, we need to understand that they will manifest themselves with hypoxia, a decreased amount of oxygen reaching the tissues. But part of the difference is bronchitis is anytime we see the suffix itis, we think of inflammation and inflammation of the bronchial tubes. And the associated symptoms for that: increased mucus production, narrowing of the airway passages, and possibly a cough. And we contrast that with chronic emphysema, which is a situation in which patients are unable to exhale adequate amounts of air. Therefore, air is trapped in the lungs and minimizes the amount of oxygen that can be absorbed. The blood is not able to receive oxygen, and the result is hypoxia. The next respiratory emergency we may consider is hyperventilation syndrome. This results in abnormally low levels of CO2 in the blood. It's relatively common and can be caused by excessive deep breathing or hyperventilation. It can also be associated by psychological factors. Now, in the most severe form, hyperventilation will manifest itself with something called paresthesia, that is, tingling in the hands or the feet. It may also be associated with chest tightness and can trigger seizures in patients with seizure disorders. A pulmonary embolism is a situation where a blood clot becomes stuck in and blocks a pulmonary artery. Now, it may travel from a distant location, such as a vein in the legs. An embolism is basically a clot that travels. Sometimes you may have heard of this situation, DVT, deep vein thrombosis. And that can occur, for example, in someone who is seated on a long airplane flight for too long, and a clot develops in their legs and then travels and obscures a pulmonary artery. That blockage disrupts flow of blood through the lungs and back to the heart, and therefore prevents gas exchange and becomes a respiratory emergency. It can be rapidly fatal if one of the larger vessels is blocked. Here we see exactly how that deep vein thrombosis may occur as that clot develops in the legs and then travels later on through the venous system, returning to the heart and into the pulmonary circulation. DVT, deep vein thrombosis. Prolonged sitting or immobilization, such as a long airplane flight or car travel. Fracture of a long bone that allows a patient to not be as mobile, perhaps they're bedridden as a result of that. Recent surgery, again, same thing. A bedridden patient is at risk for developing a deep vein thrombosis that can break loose and become an embolism. Most cases of pulmonary embolism only affect smaller vasculature, smaller portions of the lung, but large blockages are extremely dangerous. Hypoxia is the decreased amount of oxygen reaching the tissue, and anoxia, this prefix means without, is a condition characterized by a more extensive lack of oxygen supply. One particular type of pulmonary embolism is called a saddle embolus. It occludes the lungs' arterial circulation exactly at the junction between the right and left pulmonary arteries. That's why it's called a saddle. And death from this form of pulmonary embolism can occur very rapidly. One of our final respiratory emergencies is a pneumothorax, in which we get accumulation of air between the lung and the sac in which it resides, which is the pleura. That pleural space is outside the lungs but inside the chest wall. And so if we introduce air into that space, what the result can be is a collapsing of the lungs. We introduce air in between this key organ and the sac in which it resides. The most common cause of this is traumatic injury to the chest wall, and so air actually approaches from the lung into the pleural space. Less commonly, we may see rupture of the alveoli, allowing for that leakage of air into the pleural space. Now, depending on the size of the hole in the lining of the lung and the air leakage, we may get a problem that resolves spontaneously, or we may see an emergent situation that results in profound hypoxia. Now, additionally, we can have a hemothorax. If we change this prefix, we're not talking about air in the space, we're talking about blood in the space. But the same result in terms of profound hypoxia due to essentially collapsing that lung as we introduce something into the sac outside, the pleura. The final thing to discuss is appropriate talking about COVID-19, this highly contagious airborne virus that results in fever, cough, and shortness of breath, and the reminder to be on top of proper precautions and use of PPE as you work with a patient who's potentially been exposed.